This is a presentation about typhoid. At the end of presentation, there will be 10 multiple choice questions for you to practice. By the end of this presentation, the student shall be able to describe the epidemiology of typhoid fever, interpret the results of various lab investigation, plan control measures for typhoid, able to tell the role of vaccination to prevent typhoid. Typhoid is a bacterial infection which has wide variety of presentation ranging from multi-system illness to relatively minor low-grade fever with diarrhea. Typhoid is also called enteric fever, and Salmonella typhi is the major causative organism of enteric fever, whereas Salmonella paratyphi A, B, and C are relatively infrequent. About 3 to 5% of individuals who are infected they develop a chronic infection in the gallbladder. Mary Mellon, also known as Typhoid Mary, in New York, was the most notorious chronic carrier in the history. She gave rise to more than 1,300 cases in her lifetime, and later she was permanently quarantined for over 15 years. Enteric fever may occur as sporadic, endemic, or epidemic. In the past, the typhi bacilli was sensitive to first-line antibiotics, but at present, MDR strains have emerged, and without effective treatment, it leads to high morbidity and mortality, and the carrier state is 10 times more common than the cases. Coming up to the bacterial structure, Salmonella typhi is a rod-shaped gram-negative bacteria who has three main antigens: antigen O, antigen H, and antigen VI. Coming to the pathophysiology, all the pathogenic Salmonella species, whether typhi or non-typhi bacilli, when present in the gut, they are engulfed by the phagocytic cells, which then passes them through the mucosa and presents them to the macrophages. Now, in case of a non-typhi bacilli, the TLR4 and TLR5 receptors of macrophages recognizes the PAMPs, that is pathogen-associated molecular proteins, flagella and the lipopolysaccharide of the bacilli. They are recognized. So the TLR4 and TLR5 receptor, they recognizes the flagella and lipopolysaccharide of the non-typhi bacilli. And once this recognition is done, macrophages attract T cells and neutrophils with interleukin 18, which leads to inflammation and suppresses the infection. Whereas, in case of typhi bacilli, the capsular VI antigen masks the PAMPs, means the VI antipolysaccharide of the typhi bacilli. Rather, the typhi bacilli, they have a specialized fimbriae which gets attached to the pair patches, leading to more and more macrophages being attracted. The typhi bacilli co-opt the macrophage's cellular machinery for their own reproduction and multiply, and they are carried through the lymphatic system, through the reticuloendothelial tissue of lymph nodes, bone marrow, spleen, liver, gallbladder. Typhoid fever may occur at any age, but the highest incidence among the age group of 5 to 19 years. The enteric fevers are observed all throughout the year, but the peak incidence is during the rainy season of July to September. The primary source of infection is feces and urine of cases and carriers, and the disease is transmitted by feco-oral and urine-oral route. The bacteria survives in water, ice cream, food, milk, vegetables, and fruits. In water, the bacteria survive for less than 48 hours with no multiplication. In ice and ice cream, the bacteria survives for more than 30 days without multiplication. In food and milk, the bacteria survives for up to 7 days and multiplies. And in vegetables and fruit, which are grown in the sewage form or washed with the contaminated water, the bacteria survives for up to 7 days and multiply. And these health hazard is compounded by the poor water supply and poor sanitation. Man is the only known reservoir of infection as cases or carriers. The incubatory period ranges from 7 to 14 days. The cases presents the clinical feature, and during the recovery phase, They can excrete the bacilli for 6 to 8 weeks. If the carrier excretes the bacilli beyond 1 year, then the carrier is called chronic carrier. Now is the clinical presentation. The patient may present with classical feature or may show some variation. Now, the classification of typhoid is, during the first week, there is insidious onset of high-grade fever with chills, which ascends in a step-ladder fashion. There is pain abdomen, constipation, malaise, and dry cough. During the second week, along with the high-grade fever, rash appears on the trunk, which are called rose spots. There is marked abdominal distension, splenomegaly, relative bradycardia, and dicrotic pulse. During the third week, along with the high-grade fever, the patient looks toxic. There is weight loss, severe abdominal distension, pea soup diarrhea, typhoid state, and there can be complication like intestinal perforation and peritonitis. And the less commonly occurring complications during the third week are myocarditis, cholecystitis, nephritis, or osteomyelitis. During the fourth week, the slow improvement starts. The case fatality rate of typhoid is 1 to 4%. The clinical presentation of typhoid can have some variation, like there can be acute onset of fever in children, there can be diarrhea in first week, especially among the young children, there can be isolated severe headache like meningitis, there can be acute lobar pneumonia. Now the lab diagnosis. The definitive diagnosis of typhoid fever depends on the isolation of typhi bacilli through microbial culture, and the various specimens for the culture are bone marrow, blood, stool, and urine. The culture are the gold standard, but serological tests are the mainstay of diagnosis. There are many serological tests like Vidal test, then the more advanced ideal Wicks test, which detects the IgM09 antibodies, the Typhi which detects IgM and IgG, then Typhi.M, which specifically detects IgM. The main principle of Vidal test is that the homologous antibody present in the serial double dilution of patient's serum react with the respective antigen to gives visible agglutination. The serial double dilution of patient serum taken in the tube are 1 is to 20, 1 is to 40, 1 is to 80, 1 is to 1, and so on. The highest titer of serum dilution, which gives the visible agglutination, is taken as significant in Vidal test. Here in this picture, you can see the highest titer for visible agglutination is 1 is to 160. The antigen used in the reagent are O and H antigen of Salmonella typhi. Also, H antigen of Salmonella paratyphi is used. Titer of 1 is to 80 and above of O antigen and 1 is to 160 and above of H antigen are taken as significant in the Vidal test. Now, this is a here you can see that the result mentions that the serum was non-reactive, means the Vidal test is negative. In this report, no agglutination of serum was seen for typhi O antigen, whereas for H antigen, agglutination was seen at a titer of 1 is to 20, which is less than the value which is taken as significant. There are limitations of Vidal test. The Vidal test may be falsely positive in patients who are vaccinated or had previous infection with Salmonella typhi. Then there may be cross. So these days, the Typhi kit, which is more specific, has superseded the Vidal test. Now is the treatment of typhoid. For the cases, the drug of choice is fluoroquinolones. In case of MDR, the drug of choice is azithromycin of ceftriaxone. And if the patient is very toxic, steroids can be given. And in case of carrier, the drug of choice is ampicillin or amoxicillin plus probenecid, whereas the treatment of choice is ampicillin plus cholecystectomy. Coming over to the control measure. Control measures has to be taken at 3 levels: control of reservoir, control of sanitation, and vaccination. At reservoir level, the most important is early diagnosis of the patient, of the cases, followed by mandatory notification and treatment. Then isolation of the patient till 3 negative stool and urine reports are obtained on 3 separate days, and a disinfection of stool and urine, and follow-up examination of stool and urine after 3 to 4 months of discharge, and again after 12 months to prevent the development of carrier state. For carrier, identification and treatment should be done, and they should be kept under surveillance. They should be prevented from handling food, milk, or water of others. At sanitary level, poor sanitation is the weakest link in the typhoid control measures. Safe water and food hygiene are essential measures to interrupt the transmission. Vaccination is a template for selected persons, as it does not provide 100% protection. It is recommended for those who are living in endemic area, and also to those groups at risk of infection, such as school children or religious gatherings. Both injectable and oral vaccine is available. There are two types of injectable vaccine. One is based on subunit antigen, and the other is the conjugated vaccine. The VI antigen is conjugated with tetanus toxoid. The subunit vaccine can be given to individuals more than 2 years of age. One dose IM is given, which is whereas the VI antigen vaccine is given only to the infant. The oral vaccine is live whole cell vaccine, which is named as TY21A vaccine. It can be given to individuals more than 6 years of age. It is available as 3 or 4 capsules which are taken on alternate days, and the dose has to be repeated after every 3 years.